Understood. Which, especially with the initial dosing, always kind of confused me when it's 1 gram up front and then an 8-hour drip, which obviously is going to take you way past your 3-hour window. But, I drank the Kool-Aid and just did it the way they wanted it because I didn't want to think that hard about it. But what I do see happen, we have a patient who's bleeding. We get somewhat control. We've done the TXA. We've done a resuscitation. Like things are quasi-stable. Some reason in transport or for whatever reason, the patient starts bleeding again. And the question always comes up, like, can I hit him again with TXA? Is this a new bleed? Did I restart the clock? Is it when is it okay? And obviously I have no lab, so I can't tell. Did the original TXA wear off? So in that kind of situation in transport, patient starts bleeding again, hemodynamically unstable again. Now, would you send the TXA and or would you be like, nope, 3 hours, we're not touching it no more with that anyway?
Yeah. So I guess maybe to understand your question, maybe the TXA wasn't given initially. It was given. Okay. And now you have a new bleeding episode on top of that. Okay. Yeah, that's a good question. I think that, that kind of leads into, the way I use TXA and just understanding the pharmacokinetics of TXA administration, right? So we think that just by a study that we did in large animal studies, about 25% of your viable and active TXA will be washed out in a hemorrhage model, right? So that was one of our big questions is like, do we need to redose TXA at interval times in the operation, especially when we have, more than 25%, or maybe I'd say a quarter blood loss or half blood loss after a certain number of units that are given and the patient's doing. I think it's very reasonable to do that if there's ongoing bleeding. So to take that back to your question, I would say, yes, redose that patient with TXA. If it's just minor skin bleeding, but if it's enough bleeding to cause hypotension, I would say, yeah, I think that's a very good reason to redose that TXA.
Yeah. I mean, I could see something like, fracture liver or spleen or something. And then just during transport, something opens back. And then that question comes like, well, I can't do anything else other than give blood and I don't have lots of it. So I need literally any other help I can get, and this is where I'm at.
Yeah, and you bring into one of the big questions that I'm just generally interested in too. I've never been a combat medic. I've done this my entire life as a surgeon, but one of the big things that I've always tried to understand is people like yourself and your job, right? Because it's so easy for us to make recommendations for administration of drugs and things like that when we have a hospital standing behind us. Or even just a few more team members like in my military to help with things, right? So we try to make it practical use, and that is something of big interest in outside of TXA too, just in general. Like, how can we make this for the one person that's alone and afraid out there trying to do this by themselves, manage, in a mass casualty situation, and I think that goes back to why we have the TCCC guide, why we make it very standardized, and I know that there's a lot of thought for that exact purpose put in.